Good evening, everyone. We'll just give it a couple of minutes to make sure people have a moment to log in. Okay, I think we'll get started. So good evening again, everyone, and thank you for taking the time to join us for our British Columbia Sienna-wide resident and family town hall. The COVID-19 vaccines remain a big topic on everyone's mind, so we wanted to provide you with an opportunity to hear the most current information directly from our medical professionals. We hope the discussion tonight provides you with an understanding of the vaccines, the new variants of concern, and what we're doing to help continuously manage the situation and support our residents, team members, and all of you. With so many participants on this webinar, we weren't able to open it up to live questions. However, we did provide an opportunity for you to submit your questions in advance, and we did receive very many. So thank you to all of you who took the time to do that. We took the most commonly asked questions and combined them into themes that we will go through, hoping to touch on the most of the questions that are important to you. We did note that some of the questions were specific to individuals. So for anyone who had a personal health related question about the vaccines, we ask you that you please reach out to your residence team or to your own personal care provider to determine the best route for you. Now I'd like to introduce you to our guests for this evening. Dr. Andrea Moser is Sienna's Chief Medical Officer. She's a family physician with a focused practice in the care of the elderly, a certified medical director, and an associate professor with the Department of Family and Community Medicine at the University of Toronto. She has an extensive background and interest in the care of seniors with a focus on long-term care medicine, and has been an advisor to the Public Health Agency of Canada, among other organizations. At Sienna, Dr. Moser is focused on enhancing the medical and physician support provided to our residents, as well as supporting our management of the COVID-19 pandemic and preparing for any potential future outbreaks. We're also joined by Dr. Allison McGeer, Chief Infection Prevention and Control Consultant to Sienna. Dr. McGeer is the premier infection prevention and control specialist in Canada. She's a professor in the Department of Laboratory Medicine, as well as the Department of Pathobiology and Public Health Sciences at the University of Toronto. She advises multiple levels of government on pandemic prevention and management, including Canada's National Advisory Committee on Immunization and the Infection Control Subcommittee of Ontario's Provincial Infectious Diseases Advisory Committee. You may have seen Dr. McGeer interviewed on radio, TV, and quoted in newspapers, as she is a sought-after expert in this field. With Sienna, Dr. McGeer has played an important role in guiding our teams to effectively manage outbreaks and prevent further spread of the COVID-19 virus, as well as preparing sustainability plans for the future. And we're also joined by Dr. Anthony Tran. Dr. Tran is an experienced hospitalist with a full family practice and a focus on geriatrics. And he's also medical director at Nicola Lodge, as well as 5 other long-term care communities in the Lower Mainland. He's also a physician lead for the pandemic response for long-term care and assisted living with the Fraser Health Authority. So we thank all of our experts for joining us tonight. And we will now begin our presentation with a brief overview from Dr. McGeer. we're just going to switch screens so that Dr. McGeer can share her screen and walk you through this. You're on mute, Dr. McGeer.
Thank you, Maureen.
No problem.
Natasha, I think you need to go down to the control at the bottom and enable participant screen sharing.
Maureen, that's you. You're the host.
Got it.
Got it?
There you go.
Thank you. The key is finding the right. Sorry.
No problem.
Thank you for your patience, everyone, while I get the right slides up. My apologies. Okay, so let's talk a little bit about what's new in vaccines and the vaccines that are coming. As you all know, we've got some of two different vaccines in Canada at the moment, both mRNA vaccines, one made by Pfizer and one made by Moderna. And in the clinical trials before they were authorized, very successful at preventing infection, particularly serious infection in vaccinated people. You can see that their efficacy is not 100%. That's generally true of vaccines. There's no vaccine that's 100% effective. So that means that you can still get infected after you've had the vaccine, but you're much, much less likely to be infected. There's now 3 new vaccines that Health Canada is considering licensing that we have options on doses for in Canada. The first one from AstraZeneca, one from Janssen, and one from Novavax. The AstraZeneca trials are hard to interpret, 2 different trials with 2 different vaccine efficacies. And that really emphasizes the difficulty of comparing one clinical trial of a vaccine to another clinical trial of a vaccine in the midst of COVID, different definitions of things, different testing regimens. So all of these vaccines are actually good vaccines. There's a temptation to look at the Janssen vaccine, which is 1 dose, and say it's not quite as good. But in truth, it looks like it just takes a little bit longer to be effective. So we're going to have to wait for more data to really get a good assessment of whether there are differences between these vaccines. You'll see, and we'll come back to, that when you look at the efficacy estimates, the Janssen vaccine trials, they didn't look at the exact strain, but when they looked at countries, the vaccine was not quite as effective in South Africa, that's the SA, as it was in their United States sites. And the Novavax vaccine, they actually looked at strains, and you can see again that the vaccine was not as good against the South African variant of the vaccine as against the original coronavirus strain and the UK variant. Mind you, 60% efficacy is still pretty good for a vaccine, and all of these vaccines look like they're more effective than that at preventing serious illness and hospital admission. So it's still looking like there's not much difference between the vaccines. And that means, any vaccine that you get offered is a good vaccine to have. But we'll be watching very carefully as time goes by whether there are some vaccines that should be recommended for particular populations. I think all of us are very happy at the moment that it's the Pfizer and Moderna vaccines that have been rolled out to long-term care and retirement homes because we know they're both safe and very effective. And so we're a little less worried about efficacy in them than we might be with other vaccines. Next slide. Except I'm doing the slides.
That's you. Yeah.
Good. That would be Allison. I'm so sorry, guys. Okay. Been a long day, or maybe a long year, it's only February. All right. So a couple of reminders about things that if you have been on the town hall before, already. When they appeared, the vaccines seem to have appeared out of nowhere. They came really quickly and somewhat unexpectedly, and that's a little bit scary. But it really is important to recognize that the reason the vaccine came so quickly was because everybody understood how important it was and spent a lot of time over the last year working as hard as they could to make these vaccines come fast. It also looks like we've kind of lucked out with this coronavirus, that it is easier to make vaccines for this virus than it is to make vaccines against some other viruses and bacteria. 60 years into flu vaccines, we're still having trouble making a flu vaccine that really works well. But the coronaviruses, pretty much all of the ones that we have so far, are working really well. So it's not because we cut corners in any way. It's not because people didn't do everything they usually do. It's just that people worked really hard to make it go quickly. It's also important to remember that there's no point in this trajectory where people compromised vaccine safety. These vaccines are meeting exactly the same safety standards that every other vaccine meets. We're not changing anything about how we license vaccines, and we're very fussy about it, which is in part why Health Canada is taking longer than some people might like to review and approve other vaccines. They need to be really sure before they approve them that they're safe and effective. The second thing that's been really obvious about the COVID vaccines coming is that there's all sorts of things we don't know starting the vaccine program. So we don't know how long protection is going to last, whether it's going to be August when we're going to need to get a booster, or whether it's going to last a lifetime. We didn't do the clinical trials in all the different population subgroups, particularly not in people who are immunocompromised, people who have other underlying conditions, residents of long-term care who are very old and frail and might not respond as well. And when we started the program, we didn't know whether there were going to be very rare adverse events to vaccines. You do the clinical trials, there's 20 or 30,000 people in those clinical trials, and those people get watched very carefully. But if you have an adverse event that occurs at a rate of 1 per million doses, which happens sometimes, you can't tell that until the vaccine program starts. If you don't live vaccines, if you're not used to the development of vaccines, these all look like questions of uncertainty, things you ought to know. But in truth, you never know them, okay? You've never started a vaccine program if you want to know how long it lasts. Hepatitis B, we started vaccinating in 1970. If we waited to know how long it lasted, we'd still be waiting, okay? It lasts a lifetime. So some things you have to learn as you go along with vaccines. And so we will be learning a lot over the next few months about COVID vaccines and how we need to use them going forward. Next slide. Allison, stop saying next slide. So one of the things we do know, however, with these vaccines is about safety. And that's because we've used so many of these vaccines so quickly. So this is a graph of the proportion of the population that's had at least one dose of a vaccine by country. And you can see the top of the list are, that's Israel in second, and the United Arab Emirates, with just over 40% of their entire population that's had at least one dose of the vaccine. And when you add up the vaccines in all these countries, that means that so far we've used more than 50 million doses of the Pfizer or Moderna vaccine. And the good news about that, besides all the people who are protected from COVID, is that that means that we by now should have detected any rare serious adverse events that are going to happen. And the only adverse events that we've detected are serious allergic reactions. Serious allergic reactions occur to all vaccines and all medications, usually at a low rate. And these vaccines are not exceptions. So anaphylaxis, which is an allergic reaction of such severity that it needs treatment in the emergency department or sometimes hospitalization, occurs at a rate of about 5 cases per million doses of the Pfizer vaccine and about 3 cases per million doses of the Moderna vaccine. That's a little higher than some other vaccines, but it's still a really low risk. And none of the other adverse events that sometimes occur very rarely with vaccines have been detected with these mRNA vaccines at all. So that is very good news. We know now that other than serious allergic reactions, these are very safe vaccines to use. Okay. One really common question for all of us, because we have shortages of vaccine everywhere in the country, and we're all talking about how best to use these vaccine doses, is how much does it matter if your second dose is late? And when these vaccines were developed, the big concern about these vaccines was they weren't going to work well at all. And everybody was convinced that we were going to need 2 doses of these vaccines to make them effective. So both Pfizer and Moderna made pretty short intervals between the 2 doses because they knew they were developing these for a pandemic and we wanted to protect people as quickly as possible. So they made the intervals as short as possible. And then they did the clinical trials, and we found out 2 things. First of all, these vaccines are awesomely effective, okay? Much more effective, in fact, than we were expecting them to be. And secondly, they work after 1 dose. And this is the graph from the Pfizer data. The graph for the Moderna vaccine looks exactly the same, that shows you that. So bear with me for a moment. The blue line on this graph is the cumulative number of COVID infections that occurred in people in the trial who got placebo. Okay, so they didn't get vaccine at all. And you can see that they steadily got COVID over the course of the trial. People who got the vaccine, this red line labeled BNT 162b2, you can see you go up to about day 14. And if you look in the inset, you can see the early time. So for the first 10 days after you get your vaccine, it doesn't provide you with any protection at all. Not surprising. You need some time to generate the immune response that will protect you. But starting at day 10, people who got the vaccine just stop getting infected. And if you measure the vaccine efficacy starting from day 10 out to the end of the trial, it's not different for the whole time. And for the first 3 weeks before the second dose, it's 85%. That 85% might be a shade less than the 95% final, but it's really good. So when you add that to the fact that we know that for vaccines, you shouldn't ever give vaccines too close together, but it doesn't really matter how far apart 2 doses are. So with most vaccines, what we say is, do not give the second dose before 28 days, but you don't have to repeat the course or worry about it if the second dose is delayed. And that's what we need to be saying for COVID. It's actually, you'll probably get a better response to the second dose if your vaccine is a little delayed past 21 days. If you get it at day 28 or 35 or 42, it'll probably give you a better boost and for longer. And as far as we can tell, that first dose will protect you out for at least that long, and maybe even longer. One of the questions that people are asking is, do you actually need the second dose? And I think the consensus, at least until we know better, is that you should have the second dose. It definitely gives you a boost. It'll make the vaccine last longer, but you don't have to worry about getting the second dose early on. Okay, so lastly, what about new variant strains? This is what everybody is worried about now around the world, in fact. In Canada, we are increasingly detecting them. We had none of these in November or the early part of December. They started to appear in later December, and they are increasing fairly quickly. So we don't have a good sense of how long it'll take, but let me give you a sense of how long it took in the United Kingdom. So this map shows you that these variants started in September in the very southeast corner. So by the end of November, in nearly 100% of their cases were due to the variant. But in the north of England, in the white, it's still less than 5% of cases are due to the variant. And then as you walk through the next 8 weeks, you see that you get increasing numbers of the variant everywhere, so that by the 11th of January, so 6 weeks later, you can see that they're up above 50 or 60% of the new variant. And so it's that kind of pattern that we are expecting all across Canada, that we will go from where we are now, which is 3 to 8 or 10% of the variants in different geographic areas to 50 or 75% in 5 or 6 weeks. And that's a problem because these variants are much more transmissible than the current virus we have now. They bind better to the cells of your respiratory tract, and if you're exposed to them, you're more likely to get infected. And so what that tells you is that if we maintain our current state, so across the country, we're doing pretty well now. Cases are coming down nicely. But when the new variant takes over, suddenly our precautions will not be working as well. And much of the country is in danger of going from a situation where the cases are decreasing to a situation where the cases are actually increasing, even though our control measures have not changed. So what are we doing about this? Well, the variant is now spreading across most of the rest of Europe, not surprisingly. And in general, Europe is focused on improving adherence to the current public health interventions. So it's what we've been doing, only let's do it better and more effectively. In the UK, they have gradually increased the strength of their lockdowns and the intensity of lockdowns. And they finally ended up having to close their schools again, which is something they tried really hard to avoid doing. And with that, they're seeing a decrease in cases now, but they have much more intensive measures at the moment than we do. And in some countries, people are talking about moving to medical masks in the community because of the evidence that medical masks may be more reliably effective against the spread of droplets than cloth masks. So expect to hear a lot more discussion about masks and whether there are things we can do with masks that will improve protection in the community over time. In Canada, there's still not a consensus about what we should be doing about variants and whether there are things we can do better. Each public health unit has, of course, been worried about variants in their area, and a number of them, at least in Ontario, have implemented some additional precautions in outbreaks and in areas where cases have been seen where they're worried about high risk. So I think we can expect over the next period of time that there will be some differences in different provinces and in different health units in the provinces and health authorities about exactly what is being done. In Quebec, they have moved to requiring N95 respirators in hospitals as opposed to what we do in Ontario and BC, which is a risk assessment about whether you actually need an N95 respirator. I think in Ontario, we're having discussions about probably not about going to respirators, but about whether we can do things that will make masks fit better so that they will be more effective. So there's still a lot of open questions at a public health level about how we're going to respond to the variants and what we need to do. And we have probably 2 or 3 weeks before we really see the impact of the variants kick in, and we'll have to sort it out during that time. And I will shift over here and give Natasha and Maureen back the screen so that we can switch over to Andrea talking about specifically what we're doing at Sienna. Hold on. Thank you.
Thank you very much. So we'll just give Natasha a second to bring up the deck. And I think we're actually going to move right into your questions. So thank you again for everyone who submitted questions in advance. Again, these reflect what those questions were. So the first bucket focuses on vaccine safety. How can we be confident about the long-term effects of mRNA vaccines? So how long they last for, whether it's going to become an annual vaccine that we have to get. Can you discuss any adverse reactions that we might have to the vaccine, and how are residents monitored after getting vaccinated to ensure their safety? So can we start with you, Dr. McGeer, and then we'll move over to Dr. Moser or Dr. Tran?
Yeah, for sure. So as we said, we don't know at the moment how long these vaccines are going to last. There's a reasonable possibility that the virus will continue to change and it will turn into something a little bit like influenza, where we'll need to change the vaccines from year to year to have an effective vaccine each year. If that happens, probably what we'll do is we'll have a combined COVID and flu vaccine. So it'll still be one shot in the fall. It's just that you'll get a coronavirus vaccine with your flu vaccine at the same time. But I think there's still room to hope that the vaccine will last for longer, and that maybe we will need a few boosters, but we won't need routine annual vaccination. And we've talked about serious adverse events, but not about less severe adverse events. This is definitely what people call a reactogenic vaccine, which means that when you get it and your immune system kicks in, you do get some symptoms. Not so much with the first dose, but with the second dose, about 1 in 5 people have a fever or just feel miserable for a day or get achy. It's if you are old enough to have been eligible to get the inactivated herpes zoster vaccine, that vaccine is even more reactogenic. So more people get adverse effects to that vaccine than to the COVID vaccine, but it's still, the COVID vaccine does have that adverse reactions. They usually last a day or two at the most, and they're not serious, but some people do feel quite miserable with it. And I'll switch over.
Yeah. Dr. Moser or Dr. Tran, do you have anything that you'd like to add to that as well?
Yeah, just to comment on how do we monitor patients post-vaccination. So we know that the biggest thing that we're worried about with vaccination is any allergic reactions. So people who are getting vaccinated, they will be monitored for at least directly for at least 15 minutes post-vaccination. And all the vaccinators will have access to epinephrine or adrenaline to give in the situation that somebody does have a major allergic reaction at the time of administration. Post-vaccination, people are being monitored with the normally daily assessment tools that Sienna has. So people's are getting their vital signs checked and making sure that they're not having fevers, and nursing staff continue to monitor for any signs of infection. If somebody was to show signs of flu-like symptoms post-vaccination, what we're recommending here in BC is that we would still be treating them as if they would potentially be COVID positive, and we would be swabbing them, and we would be putting them on droplet precautions and watching them to see if their symptoms resolve, and make sure that they don't actually have a active COVID infection.
Okay, thank you. So we'll move on to the next slide, please. So in terms of eligibility, what individuals are eligible to receive the vaccine as it relates to whether they were or weren't COVID positive previously, as well as any other health matters that might be present? Dr. McGeer, are you able to respond to that?
So one of the great things about these vaccines being so safe is there's very few people who can't receive them. On the list now is people who are allergic to a compound called polyethylene glycol or polysorbate, which is related. That's because these vaccines contain that, and that's probably the part of the vaccine that's causing the allergic reaction. So it's very uncommon to be allergic to polyethylene glycol, but if you are allergic to it, then you will have to wait for one of the other vaccines coming along after the 2 vaccines we have now. And we're currently not vaccinating children because children don't get as severely ill with COVID. And it's not necessarily that we don't want to protect them, because their condition of multisystem inflammatory syndrome is a serious condition, occurs often enough to worry about. But we're not going to vaccinate them routinely until we know that the vaccine is safe and effective in children, and those studies are running now. We waited to see whether it was safe and effective in adults first, and now we need to be a little bit patient about vaccine for children. Vaccine is recommended even if people have had COVID before. We do know that having had COVID protects you for at least 5 or 6 months after you've had the infection, but we don't know how long it's going to protect you. And you'll certainly do better if you have a boost from the vaccine. So at the moment, we're recognizing that people who have previously had COVID should be getting their 2 doses of vaccine just to make sure that their protection is optimized. People who currently have vaccine it's recommended that they wait until after they get better. And that's for 2 reasons. Partly, you don't want to confuse what might be a vaccine adverse effect or from something that might be your COVID getting worse. And so it's better to wait. It's also true that people who have a significant infection may not respond as well to vaccines. And so it's better to wait until you've recovered from COVID before you give either the first or second dose of vaccine, depending where you are when you get it. That worry about not responding well to vaccines does not apply to somebody who just has symptoms of the common cold. We know from lots of other vaccines that people's immune systems, when they have a cold, are working just as well as usual, and it's okay to get any vaccine. Of course, if you're a staff person at a long-term care facility or a caregiver, you're not going to be able to get your vaccine if you have cold symptoms because you'll be home self-isolating because it might be COVID, at least until you have a negative test. So it's not really relevant at the moment, but it's a general truth about vaccines. We did originally say that we might not routinely vaccinate people who have immunosuppressive conditions or on immunosuppressive therapy because they might not respond as well to the vaccine as other people. But having looked at risks and benefits of vaccine, the general consensus is that these vaccines work so well that they will almost certainly work to some degree in people who are immunosuppressed, and that the benefit from them will be significantly greater from the risk, even if they don't work perfectly. So generally speaking, the recommendation now is that people who are on immunosuppressive drugs or have immunosuppressive or autoimmune conditions should be taking the vaccine. It's absolutely true that if you've had a severe allergic reaction before, that you are at a somewhat higher risk of getting a serious allergic reaction to this vaccine than other people. So the general population risk for these 2 vaccines is between 3 and 5 per million doses. That risk in people who've had serious allergies before might climb to as high as 1 in 50,000. So it's significantly greater, but it's still a really small number. And as Dr. Tran has pointed out, you can't run a vaccine clinic in Canada without being prepared to deal with serious allergic reactions. Your staff have to be trained, you have to have epinephrine, you have to have a pathway for treating severe allergic reactions. And as long as you have that, they can be safely and effectively managed. If you do have serious allergies, one thing that you will have to deal with is the fact that you'll probably have to wait for 30 minutes after your vaccine instead of the usual 15 minutes. And that's just adding a little bit of a safety margin because serious allergic reactions almost all occur in a short time period after vaccination, but you'll be watched for a bit longer if they're worried. People who are breastfeeding are fine to get the vaccine. These mRNA vaccines are not transferred into breast milk and will not get to the baby. There's not a reason to worry about it. Pregnant women, we are still worried about, not because there's a particular reason to worry based on what we know, but because we always worry about pregnant women. When anytime you deal with a pregnant woman in medicine, you're dealing with 2 people as opposed to 1. And one of them is a very vulnerable child, so we're always really careful. And we originally said that we would not recommend vaccination for pregnant women. But this is a pandemic, and there are lots of pregnant women who are at risk of COVID. And we know that when you're pregnant, COVID is more severe, and you risk losing the pregnancy due to COVID. So people have now said pregnant women should talk to their providers about what's best for them as individuals, balancing the risk of COVID against the potential risks of vaccine, and make a decision for themselves about whether or not they're going to get vaccinated.
Thank you. So moving on to the next slide, we're looking at the timing and process for first vaccine doses. Do we know when all retirement residents will have access to the vaccine? When will essential caregivers and the general public have access? And do you know when and where the vaccinations will actually take place? So I might turn this over to Dr. Tran to start, and Dr. Moser as well, if you've got any insight into vaccination rates so far in retirement.
Yeah, so all long-term care and assisted living facilities have been vaccinated with the first round already. Some are starting to get the second round shortly. Nicola Lodge is going to be receiving their second dose starting on Saturday. And anybody who missed their first dose and is willing or qualifies for it will be getting their first dose as well on that day. In terms of essential caregivers in BC, they are vaccinating essential caregivers at least through Fraser Health and through Vancouver Coastal. This is a decision that each health authority makes as to how they're going to roll their vaccinations. But in Coastal Health and Fraser Health, all essential caregivers are being vaccinated, and they have already been given information how to book themselves in for that. General public, that's based on the information that was released not too long ago. They will start with the phase 2 likely in March, as long as all the supply chain works out the way that we're expecting. And where they will actually take place, I think they're still formulating that plan as to, for the mass public, where they're going to be doing that. I don't know of any concrete answer for that yet.
Okay, thank you. Dr. Moser, do you have anything to add?
Just in terms of percentages, so in BC, we just had an earlier call in Ontario today, and I think BC is doing better in terms of the retirement home accessibility to vaccines. So of the team members in retirement, almost 50% of the team members or staff have received their first vaccine, and almost 69% of the residents in retirement homes in BC of the Sienna homes. And then for long-term care, it's about 70% of the staff have received at least first dose, and upwards of 90% of the residents have received one dose in long-term care. So numbers are looking really strong in BC.
Great, thank you. So we'll move on to the next slide. In terms of vaccine delays, can you please speak about how the delays will impact residents, staff, and essential caregivers in getting their first or second dose? And will the delay in getting the second dose impact efficacy? And what is the safe period between the first and the second dose? So Dr. McGeer, maybe I'll start with you if you can.
Yeah, obviously our overall vaccine delays are having an impact on access to vaccine for resident staff and essential caregivers. I think it's obviously hasn't impacted residents in long-term care and retirement in British Columbia, but it has made, I think, scheduling more difficult for staff and essential caregivers. And so there's still not easy enough access to vaccine so that we're able to deliver vaccine to everybody who wants it for their first dose. For the second dose, we are trying to hold on to people getting their second dose, particularly residents, because they're the people who are least likely to respond well to vaccine and most likely to benefit from a second dose. For those of us who are staff and essential caregivers, the data are very clear that delays in the second dose is not going to impact efficacy. And at the rate that vaccine supply is picking up, we're not delaying second doses probably beyond 8 or 10 or 12 weeks. The United Kingdom is actually officially gone to 12 weeks for delaying doses. That's a Public Health England recommendation, and these are smart, careful people. They would not make that recommendation if they were worried about the loss of efficacy. And as I said, the later you get the second dose, probably, the better protected you are for longer. So at worst, it might be trading off a little bit less efficacy now for a vaccine that's going to last you longer and protect you better for variants throughout the spring and summer. So I think delaying the second dose it's anxiety provoking for everybody, but it's probably actually a good thing as opposed to a bad thing.
Okay, the next slide, please. So after the second dose, are there any increased side effects? Can you still be infected with COVID-19 after both doses? Or can you still transmit COVID-19 to someone else after you've had both doses? And how long are you protected for after the second dose? So maybe Dr. McGeer, I'll start with you again, if you can.
Yeah, the second dose does definitely result in more side effects. You get a good response to the first dose. Your immune system is primed and ready to go, and more people feel it with the second dose. Now, most people who get the second dose still don't have adverse events. They still don't have side effects, but 1 in 5 or 1 in 6 people will get a fever or get achy, just not feel well for a day or two. It's not serious. It's not going to continue, but it can interfere with activities of daily living for the day or two after you get your vaccine, no question. And yes, you can still be infected with COVID-19 after both doses. Remember, the vaccine efficacy was 95%. It was not 100%. So you're much less likely to get infected. And we think that the efficacy against severe disease, so hospitalization, ICU admission, may be closer to 100% than 95%. But you can still definitely get infected, and you will be seeing stories of people who've been infected after 2 doses of the vaccine. That is normal when we're giving as many vaccines as we are. The third question is the big one, okay? Because when we do clinical trials of vaccines, we always start with, does the vaccine protect the individual being vaccinated? And that's how we did trials for COVID-19. And vaccine's very good for that. But there's a second critical question about COVID, which is, if I get the vaccine, does it mean that I also won't get an asymptomatic infection or a very mild infection, but I'll still shed virus and be able to pass it on to other people? And that is not likely, okay? It is most likely that when we prevent infection, we will also significantly reduce asymptomatic infections and transmission, but we don't know that. And it's because of that we're being very, very cautious about reopening when people have had their 2 doses of vaccine, and why anybody who's had their 2 doses of vaccine still needs to be using all the public health measures, keeping your distance, wearing your mask, doing all the things that you were doing after you get vaccinated. There's a real tendency to, once you've had the vaccine, to say, yes, this is okay now, but it's not okay yet, okay? We still need to know that people can't transmit. And so we're going to be recommending the same precautions for everybody who's had their vaccine until we know that. And I think we've already talked a little bit about how long you're protected after the second dose. I'm still hoping for forever, but the advent of the variants, I have to say, is making us all think that it is likely that this is going to be something where you are going to need repeated boosters at some interval over your lifetime.
Okay, thank you. So the next set of questions is about the variants of concern. So you did touch on those, Dr. McGeer, but a few additional questions around whether the vaccines work against the variants. Does rapid testing help identify the variants? If you have already had COVID-19, can you still get a variant of the virus? And what makes the variants more transmissible? So you've touched a little bit on some of that, but are you able to answer these questions as well?
Yeah. So far, the good news is that the 2 pieces of good news. The first piece is that all of the vaccines we have appear to work pretty well against the variant from the UK, which is the first one that's coming to Canada. And the Pfizer and Moderna vaccine look like they're going to work better against variants than other vaccines. So another reason to be really happy that those are the vaccines we have in long-term care and retirement. But there may new variants, so we are going to have to keep an eye and understand how well the vaccines work against what's coming up. The good news is that, as with flu vaccine, we can change the vaccine and adapt it. And with mRNA vaccines, it's much easier and faster to make a change in the vaccine to adapt to new variants. So the companies who make mRNA vaccines, and there's Pfizer and Moderna, but there's also some others coming up, are working hard now to get the new vaccines ready to go and tested, so that if we decide that we need to shift to a vaccine against a variant, it'll be only probably a matter of 6 weeks or 2 months before we can get those new vaccines out. The rapid test, any test that is licensed in Canada for the detection of COVID will detect variants as well as anything else. That is something that you sometimes have to, diagnostic companies sometimes need to adjust as they go, but at the moment the variants are fine. Any of the tests will work for them. And yes, we are worried that people who've had the old strain of COVID may not be completely protected against variants. Again, probably true that if you do get infected, it won't be as severe as it might otherwise have been. But again, you know, that's a probably, not a certainty. And a piece of that explains why we're being, with the variants coming, we're being so precautionary about releasing restrictions in long-term care and retirement, because the last thing we want is to get overconfident about how well protected people are and allow outbreaks to start again. And what makes the UK variant more transmissible appears to be that it can bind to the cells of your respiratory tract and invade more easily than other variants. So it's got a change in the proportion, the part of the protein that binds to the cells in the back of your nose and throat. And if you're exposed, it is more likely that you will get an infection from it.
Okay, thank you. So next, will the vaccine be mandatory at some point, even though it is not right now? And are team members declining to get vaccinated? And how are you motivating staff to get vaccinated? So maybe Dr. Moser, I'll start with you, and then Dr. Tran, if you have anything to add as well.
Sure. So as of right now, the vaccine is not mandatory, just as our approach with influenza vaccine is. It's not mandatory. Our goal at Sienna is to make sure that all of our team members, all of our residents, all of our families get all the information they need to make an informed decision about whether or not to take the vaccine for themselves. I think one of the things that we're messaging a lot is there may be side effects from the vaccine. You get really sick with COVID. So again, a short term, a couple of days of feeling not great is not a bad trade-off for preventing severe illness and potentially, you know, dying from COVID. We do have some team members who are declining to get vaccinated. So what we're keeping an eye on is how many people are we getting consent from for the vaccine. And we have about, it's a low number of team members who've actually said, no, I'm not going to have the vaccine, or I don't want the vaccine, versus another group that we're calling where there's some vaccine hesitancy. So they just don't want to get it yet. They want to see what's happening with their other colleagues or other people they see get the vaccine, and slowly we're seeing those numbers turn around. At Sienna, we're doing a lot to try to encourage our staff to get vaccinated. So providing them, you know, access to webinars, we've done this type of town hall with our staff, both in BC and Ontario. We also have done, you know, regular communication with them. We've sent out Mythbusters about vaccine. Really engaging with the leadership in the homes to support their team members and having individual conversations with them as well if they have questions about the vaccination. Our infection prevention and control leaders have also been reaching out to team members. And then I think one of the biggest motivators is what we call our informal leaders. So the RN, the registered nurse that everybody really trusts and looks up to in that care community. The minute that person goes and gets the vaccine and says, "I've got it, let's go. This is good. I tolerated it. It wasn't so bad. Let's do this for the residents we're caring for and for our own families and for ourselves," right? So it's a win-win-win to get vaccinated. So we're not giving up on it. We're continuing on and continuing to motivate, continuing to get information out to the team members so that we want to get as many of our team members vaccinated as is possible. I don't know, Dr. Tran, if you have anything to add from your experience in BC.
Yeah, so in that same vein, I think the big thing is education. And at Fraser Health right now, we're working on a program to help the medical leaders, the facility medical, the facility medical directors to help them create a program that they can then download to educate their staff members and try to get over that vaccine hesitancy issue. And so hopefully that will be rolled out in the next week or so. And that will be another angle of attack to try to educate the staff and get them on board. I think it's, as a lot of people come from different cultures, come from different parts of the world, there's different biases or fears surrounding vaccinations. And so it takes time to get everybody educated and get everybody comfortable with the idea of getting vaccinated. And I think it's just going to take a little bit more time, especially with this vaccine being new. There's a lot of misinformation being spread in the media and in social media and just rumors amongst staff and whatnot. So it's just going to take time to break down those barriers and repeated messaging and coming at it from different trusted sources, and hopefully people will come around at the end of the day.
Great, thank you. So the next slide is about rapid testing. So is rapid testing something that we're going to be implementing at Sienna in BC, whether it's retirement or long-term care? And will it help open up residences for visiting sooner? So Dr. Moser, can we start with you? And then if Dr. Tran has anything to add as well?
So I actually don't have the answer specifically for BC, whether or not they're going to be being rolled out in long-term care and retirement. So I'm going to pass the microphone over to Dr. Tran.
Okay.
Yeah, so they're doing a pilot in VCH. They were doing a pilot study to trial out the rapid testing and to see what the results were like and whether or not it was cost effective. And I haven't seen the results yet. I don't think they've completely finished that trial run yet. Fraser Health was going to do a similar pilot, but they decided not to duplicate the work and just let VCH do it, and then look at the results that they come up with and decide whether or not it was something that would make sense for us. I think we're hoping that with these vaccinations that the need for rapid testing will be not as great, but I don't know what the long-term plans would be if with different variants, if there was an issue and the vaccinations were not as effective as we had hoped, whether or not they would look at adding that into the regimen or not.
Okay, thank you. So we'll move on to the next slide. So after vaccination, so this is kind of looking ahead at what comes next. When can we get back to normal? After being vaccinated, will there be more flexibility with protocols and visits and the interactions and the activities that residents are able to participate in? Will certain protocols like social distancing and wearing masks still be required, as well as testing? Dr. Moser, maybe we'll start with you on this one and then move around for everyone's. This is our last slide of questions as well. So final thoughts on what the new normal looks like and how fast that's going to come to us.
This is a really tough slide. I think this is, the reality is we all would love to open things up and see everybody we want to see, our family members. My daughter was saying the other day how she'd just like to go and just have a games night with her friends. Just really, we've been at this for almost a year now. Everybody's tired. Everybody's very hopeful with the vaccines, but we can't let our guard down. So we really have to keep all of the infection prevention and control measures in place, even with the vaccines in our toolkit. So we have to keep up with those visitor protocols. I saw some people in the chat saying, if I've had 2 vaccines and my family member has had 2 vaccines, can we then, loosen those restrictions? And the answer right now is we just can't. We can't let our guards down. We don't know who that 5% is that's not responding to the vaccine. We know how hard this is when there are outbreaks in long-term care or retirement. And so we just want to do everything possible to keep up those measures. So really, we're going to be keeping up those measures until the folks that are watching this, so the public health agencies and the health authorities, they're watching, they're seeing how much vaccine is happening, how much vaccine is getting in the community, how much community spread are we seeing, how many outbreaks are we seeing. We're starting to see some positive movement, but it's just not enough to say that we can stop doing all of these things that we're doing. So the physical distancing, the hand washing, the wearing the masks, we are just going to have to keep doing for a while. I know it's not what anybody wants to hear, but we really have to keep doing this, whether there's a vaccine or not. And that includes the COVID testing right now as well. Now, I think in BC that's probably a little bit different. So I'm not going to speak specifically to the COVID testing, but there still is surveillance testing, and also if people have symptoms, if they've had the vaccine, they're still going to need to get a COVID test to make sure they don't have active COVID. So I'll pass it on. Maybe Dr. Tran, you can speak to the BC.
Sure. So
yeah.
Yeah, I don't see anything changing too rapidly. I think you're gonna be limited to the same protocols that we've been following for the last few months. Hopefully with these vaccinations, we won't be seeing any outbreaks, and you won't be getting the significant limitations to daily life and to visits that outbreaks bring with them. So hopefully that will allow us to continue with the social visits that are occurring at this time and the essential visits that are occurring. In terms of testing for COVID, in BC, what we do is we test anybody who has any symptoms of COVID. So if a resident has any symptoms, they'll get tested right away, and they'll still be isolated and on droplet precautions. And that will continue to happen for the foreseeable future. And, we don't do any routine screening of patients or staff with COVID testing unless it's in an outbreak situation. And then they would follow the same protocols that they have been following for the last number of months. So realistically, this is a step forward to getting back to our previous normal, but it's not. It's only one step forward. It's not the final leap yet. So it's a baby step, and we still need the rest of society to get vaccinated and watch and see how that plays out before I would expect to see any relaxation in the current rules.
Okay, thank you. And lastly, Dr. McGeer, any thoughts on the new normal?
Yeah, well, it's just not going to come soon enough is the problem. But I think you know, with the vaccine, it is coming. It's We just don't want to take the risk that we're going to get back to outbreaks, and with you know, this is building the plane as we go. We're learning about the vaccine. We're learning about how much benefit it is and what we do and do not need to know and do after people are vaccinated. And public health people will just have to be confident enough that the vaccine is protecting residents of long-term care well enough, that we're not going to have outbreaks and we won't have more serious illness before they will start stepping back and releasing restrictions. And that's as it should be, but it doesn't mean it's not going to be hard for the next 6 to 8 weeks to as we're watching what's happening and as we're worrying about what the potential impact of variants is, and whether that's going to mean that we have to hold on for a little bit longer. Having said that, as Dr. Moser said, the indicators are good. We are seeing a decrease in the number of outbreaks and the amount of illness in long-term care residents post-vaccination. We are seeing that they are developing antibodies. So all of that is promising. It's just that we need to hold on until we're sure.
Great. So thank you, everybody. I think that brings us to the end of our session for tonight. Thank you to all of our medical professionals for joining us and sharing your expertise and your insights and your knowledge of the virus, as well as the vaccines and the variants. And thank you to all of you family members and residents who took the time to join us as well this evening. Thank you for your questions and for all of your interest in this topic. So enjoy the rest of your evening, and we look forward to speaking with you again sometime soon. All the best.
Take care.
Thank you, everyone.